Thank you, Georgian and sir, for giving me the opportunity to talk on this platform. Thank you, Team MCure. And thank you, Dr. Jitu, for the nice words. I've started sharing my screen. Is it visible?
Yeah, it's visible and your sound is audible. Carry on.
Yeah. So we have the topic oxalate and the kidneys. We will deal in two aspects. One is primary hyperoxaluria in practice. And in the second part, maybe our later session, we will deal with oxalate nephropathy and acute kidney injury. So the session objectives are to understand the role of oxalate as the key molecule in the pathophysiology of primary hyperoxaluria. We will mention pH for primary hyperoxaluria throughout the presentation. Learn about the burden patients with primary hyperoxaluria experience and the need for effective treatments. Appreciate the importance of early intervention to decrease oxalate accumulation. So pinpointing the pathophysiology of primary hyperoxaluria. Why does hyperoxaluria occur? For that, we need to know what is oxalate. Now, oxalate arises from a variety of dietary and endogenous sources and is considered an end product of human metabolism. Normally, only a small fraction of ingested oxalate is absorbed, approximately about 5 to 10%. Therefore, the majority of plasma oxalate is derived from endogenous hepatic production. So, liver is the main source of production. So, any oxalate absorbed from the diet or endogenously produced is delivered to the kidney where it is filtered and excreted as urinary oxalate. So, there is enteric hyperoxaluria and primary hyperoxaluria. Enteric due to increased colonic oxalate absorption due to GI abnormalities such as malabsorption. And primary hyperoxaluria, there is increased hepatic oxalate production. Both lead to an increase in the plasma oxalate, increases the urinary oxalate, and there is risk of kidney stone formation and other adverse renal outcomes. So there are three forms of primary hyperoxaluria and the hepatic pathways. So the pathophysiology of primary hyperoxaluria. Here you have the enzymes responsible for primary hyperoxaluria, which are highlighted in red. So in primary hyperoxaluria type 1 is due to the variant of AGXT gene that encodes the hepatic peroxisomal enzyme alanine glyoxylate aminotransferase, that is AGT, which is a pyridoxal 5' phosphate dependent enzyme which is involved in the transamination of glyoxylate to glycine. And this inborn error of metabolism lead to an increase in the glyoxylate pool, which is converted by lactate dehydrogenases to oxalate. So it is the most common type and accounts for about 70 to 80% of primary hyperoxaluria. And it is the most severe form also. Now, primary hyperoxaluria type 2 is the variant of GRHPR that encodes cytosolic enzyme glyoxylate reductase hydroxypyruvate reductase, which normally converts the glyoxylate to glycolate. And it accounts for about 10% of the cases. And unlike the AGT of PH1, this enzyme is predominantly expressed in the liver and has a wide tissue distribution, and the most common mutation is the deletion of a single base pair in exon 2. PH type 3 is due to variation of HOGA1 that encodes the liver-specific mitochondrial 4-hydroxy-2-oxoglutarate aldolase enzyme. This enzyme is expressed in the liver and the kidney, and it's a final step of the hydroxyproline degradation pathway within the mitochondria and catalyzes the cleavage of 4-hydroxy-2-oxoglutarate to pyruvate and glyoxylate. So it also accounts to about 5 to 10% of primary hyperoxaluria. So hepatic pathways, the ways to inform a pH diagnosis is a random urine sample which can be sent for testing with hyperoxaluria panel, and pH is suggested if oxalate and one of its metabolites is elevated. Hyperoxaluria panel results can help determine the pH type and depending on which metabolite is elevated, like in pH1 glycolate, pH2 glycerate, or HOG. In pH 1, the glycolate is often elevated, but in some cases only oxalate is elevated. Kidney stone events are common, and you can see the clinical stone events in patients with primary hyperoxaluria that can present with obstructive uropathy, renal colic, etc. Nephrocalcinosis and kidney failure. The effect of nephrocalcinosis on the cumulative incidence of end-stage kidney disease in patients with primary hyperoxaluria is as shown. The years after the first imaging is also on the x-axis, and the y-axis the kidney failure risk. And patients with incident nephrocalcinosis has a high risk of kidney failure than those without nephrocalcinosis. So this is incident nephrocalcinosis. The kidney failure risk is high, and without nephrocalcinosis. But see the years after first image. So it occurs in a relatively young age. So it's very important. We diagnose it without any delay. Urinary oxalate is a key risk factor for kidney failure in primary hyperoxaluria. So this is a graph showing the correlation of urinary oxalate excretion quartile at diagnosis on kidney survival over 30 years. The highest quartile of plasma oxalate has the highest risk of end-stage kidney disease. So more the urinary oxalate, that is, if it is more than 2.4, you can see the end-stage kidney disease is high. Kidney failure in primary hyperoxaluria, type 1 and type 2. This is a cumulative kidney survival in patients with different types of primary hyperoxaluria. pH 1 and pH 2, homozygous, heterozygous form, pyridoxine responding, and pH 1 other mutations, and pH 2. You can see that pH 1 is a more severe hyperoxaluria, causing more kidney failure than pH 2. So according to the severity, pH 1 is more severe than pH 2, and pH 3 is less severe than pH 1 or pH 2. Plasma oxalate and kidney failure risk, the association between the oxalate quartile and rate of end-stage kidney disease in patients at different CKD stages. You can see on the x-axis plasma oxalate quartile, and on the y-axis end-stage kidney disease, various stages, CKD stage from 1 to 3 and 3B, and the highest quartile of this plasma oxalate, the highest risk of end-stage kidney disease. So demystifying primary hyperoxaluria, how does it look like? Like one, the diagnosis of a genetic disease. We know PH is a rare disease and it's a kidney stone disease. So you are encountering in your practice a kidney stone in a young patient that is early onset. Think of a genetic disorder, familial prevalence, consanguinity of parents, an autosomal recessive 1 with 25% of the siblings being affected, recurrent kidney stones causing obstructive uropathy, and stone-related events, reduced kidney function, or end-stage kidney disease associated with or without kidney stones. Challenges in the diagnosis are there. There is a significant delay in the diagnosis in patients with primary hyperoxaluria. The age at diagnosis, it ranges from 1 to 50 years, and the diagnosis is often delayed after initial presentation with kidney stones. The mean age at symptom onset is about 9.5 years old, and the mean age of diagnosis is 5 years old. In US, it's the mean age of diagnosis is 5 to 5.5 years, especially they see more of a pediatric nephrology. By the time of diagnosis, about 20 to 50% of the patients have already reached advanced chronic kidney disease or end-stage kidney disease. So the diagnostic testing framework for PH is like urinary solute evaluation, 24-hour urine analysis, and genetic screening. So there is a diagnostic algorithm we'll present in part 1 and part 2. Recommended approach is that a patient is having a normal kidney function, stones or nephrocalcinosis in childhood, recurrent calcium oxalate stones or nephrocalcinosis in adults, hyperoxaluria along with family history with of primary hyperoxaluria, you perform a urine oxalate test. And if it is more than 0.7 millimole per 1.73 meters square per 24 hours, or urine oxalate creatinine, the ratio is more than the normal for age, you confirm with urine oxalate With repeat testing, perform urine glycolate, glycerate, HOG test, and you can confirm the hyperoxaluria if urine oxalate is more than 0.7 millimole per 1.73 meter square per 24 hours. And if the urine oxalate is more than normal for age. Yes, and obviously you need to rule out secondary causes like GI malabsorption, GI disease, very high oxalate and low calcium dietary causes, a premature infant. If the patient, this is about normal kidney function. So if the patient is having a kidney insufficiency or failure, increase serum creatinine with calcium oxalate stones, calcium oxalate tissue deposits, nephrocalcinosis. You perform urine oxalate test, plasma oxalate test, urine glycolate, L-glycerate, HOG test, just like we have already mentioned just right now. And if urine oxalate is more than 0.5 and or plasma oxalate is more than 20 micromole per liter, look for secondary causes. And if it is yes, you need to evaluate accordingly. If secondary causes are not there, you perform a genetic testing to screen for common mutations, AGXT, GR, HPR gene, or HOGA1 gene, and homozygous or compound heterozygosity for non-mutations of AGXT, GR, HPR, or HOGA1. If it is there, according to the mutation, AGXT we have told the pathophysiology is pH1, GR, HPR is pH2, and HOGA1 is pH3. And if it is not present, consider the clinical management of clinically you manage hyperoxaluria, or consider a research testing for novel genetic causes of primary hyperoxaluria. Diagnostic testing framework for primary hyperoxaluria. The lab analysis is required. A full urine analysis and examination of sediment. You can find the calcium oxalate monohydrate crystals in primary hyperoxaluria, which is more predominant than the dihydrate crystals of calcium oxalate. So if the urine analysis is showing predominant calcium oxalate monohydrate, you need to look for pH. And you can see the dumbbell-shaped calcium oxalate monohydrate, and this is calcium oxalate dihydrate. This is envelope-shaped crystals. And under polarized light, the urinary calcium oxalate dihydrate crystals look like this. And these are radio-opaque stones which are seen bilaterally. So the diagnostic testing framework for primary hyperoxaluria, you have a hyperoxaluria panel for more definitive testing for metabolites in urine seen in pH. The pH is suggested if oxalate or one of its metabolites is elevated, and you can often determine the type of pH depending on which metabolite is elevated, glycolate, glycerate, or HOG. In pH 1, the glycolate is often elevated. The diagnostic testing framework for primary hyperoxaluria, the profile will show all components that may contribute to kidney stone formation. The patient comes to your clinic for kidney stone. You do the calcium citrate, uric acid, creatinine, magnesium, volume, as well as oxalate. And in pH 1, the 24-hour urine examination shows a very high level of oxalate, and it is informative for ongoing evaluation as well as for preventive measures. So the practical scenarios, so this is a hyperoxaluria in practice. So most of the time it is a rare disease, and most of the time the diagnosis is delayed. Hello, I think I'm my own voice. So this is for the postgraduates also to understand. Yeah, now it's clear. So this is an example of a report showing the screening of a 24-hour urine examination. You can see the supersaturation of calcium oxalate, calcium 24 hours, oxalate 24 hours, citrate 24 hours, supersaturation of calcium phosphate. So this is how a panel looks like. You do a stone factor 16 screening, and this is in a 5-year-old child. It's a pediatric, and you can see like the oxalate 24-hour oxalate is only 48. So this is in this 4th month, and this is in the June. So it's only 48, and the normal range was 20 to 40. But the problem arises if you interpret a single value, and if you look at a glance what it is, you may find that there is no hyperoxaluria, or if the oxalate is nearly just above the upper limit of normal. But the thing is, in pediatrics, you need to extrapolate a little more. You need to take into account the body surface area. So taking into the body surface area for 1.73 meters squared, it is very clear that the 24-hour oxalate is very much elevated. So this is an easy example, like how the diagnosis go missed or get delayed. Another one is an example of a random urine hyperoxaluria panel. And in this sample, the excretion of glycolic acid and oxalate were elevated. And if consistent with the clinical presentation of hyperoxaluria, nephrolithiasis, hematuria, and renal failure, you consider pH. And alternatively, you rule out ethylene glycol poisoning. So this is another example of a random urine hyperoxaluria panel, where the excretion of oxalate and 4-hydroxy-2-oxoglutarate were elevated. And if it is consistent with the clinical presentation, consider a possible diagnosis of hyperoxaluria type 3 by molecular genetic analysis. So this is, you can do an additional gas chromatography, mass spectroscopy, stable isotope dilution analysis. So this is what they have mentioned. Family screening is very important. As I have told, it is an autosomal recessive disorder and sibling screening is to be done. Current preventive treatments for primary hyperoxaluria: extremely high fluid intake. You need to take about 2 to 3 liters per meter square per day, and older adolescents 4 liters per day, school age 2 to 3 liters per day, small children or infants 1.5 liter per day. Sometimes the child may require even gastrostomy, feeding tubes in the infants to maintain that much fluid intake. So there are several other medical interventions like pyridoxine and AGT cofactor. Only 30 to 50% of the patients with pH1 respond to the treatment, and mostly with a partial response. And the published literature recommend patients should trial pyridoxine pending genetic evaluation. And the starting dose is usually 5 to 10 milligram per kg per day. So a positive response to defined as a reduction in the urinary oxalate, which is more than 30%. In patients who are responsive, we continue the pyridoxine indefinitely or until liver transplantation is performed. And the patient has not had a positive response to pyridoxine, after 4 to 6 weeks, the dose can be titrated up to a maximum dose of 20 milligram per kilogram per day. And the medication is discontinued if there is no significant decrease in the urine oxalate excretion. So 30% reduction is expected with pyridoxine for a positive response. Then we have solubility of crystallization inhibiting agents like potassium citrate, magnesium orthophosphate. Diet, you have endogenous oxalate production. If it is so high, the contribution from the diet you can limit. It is recommended to avoid excess dietary oxalate intake, chocolate, rhubarb, spinach, etc. So there are medical interventions for patients with pH type 1. We have lumasiran, grade 1B recommendation. Lumasiran was approved by FDA in 2020 and nedosiran in 2023. And the dosing is weight-based for patients less than 10 kg. The initial dose of RNA inhibitor therapeutic agent is 6 milligram per kg monthly for 3 months, followed by 3 milligram per kg monthly. And for those who are weighing 10 to 20 kilogram, the initial dose is 6 milligram per kg monthly for 3 months, followed by 6 milligram per kg every 3 months for lumasiran. And for patients who are more than 20 kilogram, the initial dose is less actually, the 3 milligram per kg monthly for 3 months, followed by 3 milligram per kg every 3 months. So the other agent is nedosiran, which is recently they have approved as a second generation RNA inhibitor therapeutic agent that targets the messenger RNA, which encodes the hepatic LDH. And they have come across a randomized trial in individuals with pH type 1 and type 2, where only 35 patients were studied, aged 9 to 46 years, and 29 of them had pH type 1. And nedosiran, they decrease the oxalate in urine and approximately about half of the participants achieved sustained normal or near normal excretion between 90 and 180 days of treatment, which is sustained in a 6-month open label extension also. So the small trial actually did not detect safety concerns other than the injection site reactions. Regarding the transplantation, in patients with PH type 1 disease and end-stage kidney disease, the main options are combined liver-kidney transplant or sequential liver and kidney transplant, especially when the eGFR drops to less than 40 ml per minute per 1.73 meters square. A preemptive liver transplant can also be considered. There is an international primary hyperoxaluria register which showed the kidney survival with combined liver kidney transplant versus kidney transplant alone. With combined liver kidney transplant, the 5-year survival was 96 versus about 56% with kidney alone. Then again, for patients who are pitoxin sensitive or who have late onset form of disease, isolated kidney transplant is also possible. So primary hyperoxaluria disease progression. The kidneys are the first to sustain damage. The brunt of the injury is the kidneys are affected. The registry is data on time to end-stage kidney disease in patients with primary hyperoxaluria. A diagnosis about 20 to 50% have reached end-stage kidney disease at age 24 to 33 years. 50% of the patients have reached end-stage kidney disease, and 40 years, about 57%, and 60 years, 88% of the patients have reached end-stage kidney disease. Now, like when the eGFR drops to less than 40 ml per minute per 1.73 meters square, what happens is the kidney cannot cope up with the oxalate production and it results in systemic oxalosis. So in the eyes, you have retinal deposit and reduction in the visual acuity. You have infiltrative or restrictive cardiomyopathy, skin nodules and ulcer, low trauma bone fractures, bone deformation, erythropoietin refractory anemia. So the treatment of a progressive therapy, treatment of a progressive disease is renal replacement therapy, which is indicated earlier than in other chronic diseases due to rising plasma oxalate. So when the GFR drops to less than 40, preferably you initiate the patient on dialysis. Indicated when the plasma oxalate levels, RRT is indicated when the plasma oxalate levels exceed 30 micromole per liter. Aggressive hemodialysis is required as oxalate production continues to exceed the clearance capacity of hemodialysis, ideally daily and longer duration. The organ transplant, liver and kidney transplant is required in most of the patients with PH type 1. An isolated kidney transplant should be considered in patients who are pyridoxine responsive. Patients must have a bilateral nephrectomy. In some centers in US, they follow a bilateral nephrectomy at the time of transplant, as calcified native kidneys may be the ongoing source of oxalate, and aggressive hemodialysis post-transplant until the serum oxalate levels fall. So living with primary hyperoxaluria is a life-changing diagnosis for patient as well as for the caregivers. There is intensive intervention, pain, procedure, high fluid intake. A young age, the patient may require a gastrostomy to keep up with the fluid intake. Despite extraordinary efforts from the patients and family team, the PH can lead to kidney failure and require intensive dialysis and longer duration and potentially combined kidney and liver transplant. So how to monitor the response to therapy? In a stable patient, the response to therapy should be assessed within 24 hours. Urine oxalate with a 24-hour urine oxalate excretion test, which is done every 3 months, and if the patient is unstable, you may need to monitor more frequently. And the urinary oxalate concentration should be maintained below 0.5 millimole per 1.73 meter square body surface area. Now, there are other investigational agents like formagines, which have come across but not proved. They are bioactive factors. It has not shown to improve the outcome. Then tecqualinium chloride, which may be beneficial to restore normal peroxidal trafficking of AGT. And stiripendol, which is an anti-seizure medication that decreases the hepatic oxalate production, but these are all not proved. To summarize, we consider PH in patients presenting with kidney stones when they are particularly young, have family members with primary hyperoxaluria, nephrocalcinosis, or reduced kidney function. PH diagnostic testing framework include an analysis of oxalate and metabolites in the urine and genetic testing. Current preventive treatments include high fluid intake, pyridoxine crystallization inhibiting agents, and dietary changes. Despite extraordinary efforts from the caregiver, patients, family, especially in PH1, it can lead to kidney failure, and treatment of progressive disease include renal replacement therapy and organ transplant, kidney and or liver. Thank you.